Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas.
Welcome back to the Quorum Podcast. We're here with Dr. Gara, who's a cardiologist and runs our postgraduate department. Hello, Edith. How are things?
Hi, Aebhric, and welcome everyone back to our Quorumcast sessions. Today, the topic is really interesting because we will talk about traumatic heart disease.
That's been in the news lately, hasn't it? With the football player.
Yes. I remember that there was a lot of coverage on that story, and we will discuss that today in details.
So how frequently does this happen, the traumatic cardiac arrest?
Yes, thanks, Aebhric. I would say that it's more frequent than we ever suggest because traumatic heart disease can happen in any kind of injury affecting the chest. So, if there is a crash injury, if there is a fall, and even in the case of prolonged CPR, there can be a traumatic heart disease. So it's more frequent than we ever thought, and maybe for this reason we don't have that much experience, and also severity is, as you know, so it's affecting the heart. So unfortunately, in many cases, it's a fatal condition. So for this reason, and also for the time sensitiveness, we don't have that much experience. So first of all, I would like to define this condition, the traumatic heart disease, and also I would like to group the condition, and then this will give you guys listening a wise knowledge about this topic. In the definition, in the grouping, I would suggest two big groups. One is the blunt trauma, and the other one is the penetrating trauma to the heart.
Do you have any examples of the blunt trauma?
Yes, sure. So about the blunt trauma, I would say that as a synonym or as a definition to the blunt trauma, I would bring the Latin wording, the commotio cordis. So this blunt trauma is happening in crash injuries, in falls, and as I just mentioned, in prolonged CPR. So in any kind of accident involving the chest itself. And this is the point where I would like to discuss the case of the American football player, Damar Hamlin. So you guys all should remember that this was in the early days of January when he suffered a cardiac arrest on the pitch, and this condition just happened right after a crash on the chest. And this condition and this severe situation, this is called the commotio cordis. So what is happening in the commotio cordis? By definition, there is a hit on the chest wall, and when this huge crash, this hit is affecting the area of the left ventricle. So just to bring some anatomy for today's podcast, the nearest part of the heart to the chest wall is mostly the right ventricle. Closer to the sternum, in the medium, there is a part of the LV, the left ventricle, which is also really close to the chest wall. And when there's a huge crash on that part, this can result in commotio cordis. And it's not just the mechanical effect, but it is resulting in an electrical storm in the heart. And the timing is really crucial. So if we study ECG, there's a point where the T wave is just starting. So it's the upper part of the T wave. And in that really tiny second, the hit on the chest wall is happening in that second. That is causing a phenomenon which is really similar to the R on T phenomenon, which we just all learned a lot about during our ECG studies. And this can accelerate into a malignant arrhythmia, to a ventricular tachycardia or a ventricular fibrillation. This is what happened to this American football player, and He just went into a severe malignant arrhythmia and needed to be resuscitated. What can you do in these conditions, and how can you manage the blunt cardiac trauma at the field in remote conditions? So first of all, you need to recognize. How can you recognize? So you know the history, what has happened to the patient, and if you are aware of a chest trauma, then you can always assume that there is a blunt trauma to the heart as well. Of course, you will recognize the malignant arrhythmia. If there's any, you can look for any ECG changes, which are always non-specific. So you can look for ST segment depression, some T-wave abnormalities. Also, if you have a pocket ultrasound at hand, you can perform a quick check, and some not specific wall motion abnormalities are suggestive of blunt cardiac trauma. What do I mean on non-specific wall motion abnormalities? When they are not relevant to the ECG. So you suggest that you have some ischemic-like ECG changes in the anterior leads, and the wall motion abnormality is completely somewhere else. So that is on the posterior wall. So when you can't really match your ECG and the ultrasound, then everything just not specific, and you put together the mosaic and it looks like a blunt cardiac trauma. And also, if you happen to have a point of care blood test to check some cardiac enzymes, those can be elevated in a blunt cardiac trauma as well.
Like troponin would be elevated here?
Yes. If it's a really hard crash to the chest, then the troponin can be elevated.
This is an ECG problem, isn't it? So if you get hit in the chest in the perfect timing within the ECG, the cardiac cycle, does that mean that pretty much everyone would have this collapse, this cardiac arrest?
Yeah, it's a really, really interesting question, and thanks for that. So, no, fortunately, it doesn't mean that everyone will have it. When studying the literature, we can see that it's most frequent in male patients between the age of 25 and 35. Also, most of them have a completely healthy heart. My personal view would say that it's somehow related to the electrolyte imbalance in these patients, because many cases reported in the literature are on some professional players, even being it a football player or a tennis player. Even a tennis ball is enough to cause that kind of energy, that kind of hit on the chest wall.
Wow.
Because they can hit it extremely fast and with extreme strong hit. So the heart is completely healthy, and the literature often suggestive of electrolyte imbalance on long-term sporting conditions. So it's extremely important to keep those ion levels balanced during these prolonged sporting activities.
So are you saying that their electrolyte imbalance is going to enhance this possibility?
Yeah, I mean, for any kind of arrhythmia, the electrolyte imbalance can be a trigger, even on a healthy heart. If there's a lone atrial fibrillation, and what do we mean by lone atrial fibrillation? That means that there's no valve abnormalities, no abnormalities in the atrium itself. There's an atrial fibrillation out of the blue, and that could be related to an ion imbalance during prolonged sporting activities as well. It's good for your muscles on your extremities to keep those ion levels balanced, but it's extremely helpful for your heart as well.
So in this situation, they did CPR pretty quickly. Should they have not done the shock immediately, and would that have restarted the heart?
In a CPR situation, there's no other way to save the life of the patient, but I'm pretty sure that after initiative shock and after the return of the spontaneous circulation, they put a key effort to keep the ions balanced. And if you can do a quick blood gas analysis and you have the ions measured there, you can have a quick check what's going on and correct accordingly. So give magnesium and correct all the ion disturbances as well.
So now that this has happened once to Damar Hamlin, is he now susceptible to additional ones?
Yeah, this is really hard to answer. As a cardiologist, I say yes. Whoever suffered a cardiac arrest once has a risk to have another one. In his case, so the timing was crucial. So if that chest hit would happen a couple of seconds later, then he would have not suffered this cardiac arrest. The malignant arrhythmia would have not came. But this happened once, and it's also, so it's like you need to count the pros and cons, and that he has a healthy heart. His coronaries were checked, his valves were checked. The heart itself, cardiac MRI showed no structural heart disease, so the heart itself is completely healthy. Yeah, and we also had another case during the Football World Cup when Eriksson collapsed, and he also had a completely healthy heart. And according to the data which was available after his case in the literature, also his coronaries were completely fine and patent, and also he didn't have any structural heart disease on the cardiac MRI. I think he didn't have a chest trauma before it happened, but again, there were some literature data that maybe the electrolyte imbalance, and he received an ICD, and he's on the field again.
If you were the team cardiologist, you would say he's fit for getting back to the game.
It's really hard to answer this question. I mean, they've done a complete and really thorough cardiac checkup, and he was deemed safe to play. So from here, from far away from those professionals, I would not say that he's not fit to play. But and I can answer this question as from my personal perspective, and not as his cardiologist or something like that. That I would never ever do any professional sporting activity again after a cardiac arrest. But it's my point of view, and also, like a doctor can influence decision making. It's a personal decision of him, but it was like a long discussion, I think, between the doctors and this professional football player. And if I would have been his doctor, maybe I would somehow influence his decision not to continue the professional sporting. But according to the data, to the numbers, to the results of the investigations, to the diameters of his left ventricle, and to the left ventricle and diastolic volume, and all of those numbers, I'm sure that those were suggestive of a healthy heart, and he received an ICD, which would save his life if this would happen again. So following the objective data, yes, he is still fit to play.
Somebody with an ICD, there's two wires going into the heart, and a football player is just going to get hit again and again and again. Is that not a risk for those wires to be dislodged?
The answer is no, it's not a risk, because those wires are really flexible, and they are situated very precisely into the myocardium. I've never seen a wire being dislodged by a sporting activity. They could be dislodged, but those are more complicated conditions, fibrosis, lung disease, really large changes in the pressures of the cardiac chambers. We can never say never, but I'm not expecting a dislodged wire from a blunt trauma.
Fair enough. That's very interesting aspect of blunt trauma. What about
the other group? Is the penetrating trauma? Yeah. So that's the other group when we have the penetrating trauma of the heart. What is this? How can this happen? So mostly stabbing or gunshot trauma. So that's the pathology. How is the patient deteriorating? What is going on? So it's either a huge hemorrhage from a gunshot, or it's a huge tamponade, either from the gunshot or from the stabbing. So you can imagine if the the heart itself is injured and there's a penetration, then all of the blood, just with a couple of beats, it would go either into the thorax itself, or if the pericardium is patent, then all of those blood just goes into the pericardium and causes a severe tamponade. Let me tell you a story which just happened a week or 10 days ago here in Budapest, where I'm located at the moment. It was a stabbing crime affecting 3 policemen, and one was severely injured on the chest. One stabbing is just affected the heart itself. How can you treat? What can you do in the field? How about if you are in remote conditions? So I would say if you have a penetrating trauma on the heart in remote conditions, that's a catastrophic situation, and the survival chances of the patient is really low, because you have to get a surgeon as soon as possible. So the evacuation as soon as possible is my advice in these situations. So theoretically, how can you treat the patient? So there's a hemorrhage in the pericardium or in the thorax, and you need to solve that. So somehow you need to get that blood out of that pericardium, because otherwise it's a fatal tamponade. Maybe you can think about the pericardial drainage, which is, yes, it's invasive, but it's not as invasive as opening the chest. In these acute situations, we never recommend pericardial drainage for a couple of reasons. The most important reason is that it's not effective enough to save the life of the patient in a tamponade situation. Also, it needs experience to really quickly get to the good place, good department of the pericardium, and let it release the blood itself. But the most important reason is that in acute situations, when there's an acute bleeding, there's also an acute homeostasis situation going on, and the blood is also clotting really quickly. And for this reason, in a couple of minutes, there will be, if the patient is still alive in minutes, there will be huge blood clots within the pericardium and within that blood, and it's impossible to suck that out from a pericardial drainage. So that's the reason why it's not recommended. Then what can you do? And this is the case of this severely injured policeman. The ambulance performed first a thoracostomy on both sides because he had multiple stabbing wounds on the chest on both sides. On one side there was a severe bleeding, and on the other side some air went off the chest. So when the ambulance arrived, this policeman was already gasping and without proper circulation. So the wound, the place of the wound itself was suggestive of a cardiac injury. So they decided to perform a clamshell thoracotomy on the scene. And they identified a wound on the left ventricle itself. It was like 3-4 centimeters long, and wow. And the whole pericardium was full of blood and clots. So he already lost, I think, most of the circulating blood. And then they tried to suture the heart, the left ventricle itself. They also tried to somehow compress the aorta, but they never reached return of the spontaneous circulation. So unfortunately, this policeman died. It happened like a week ago here in Budapest, and it was quite shocking, because these type of crimes, it's not something happening on the streets of Budapest. And yeah, maybe we are all aware that unfortunately they are kind of frequent in London, and the London helicopter ambulances, they have some experience in handling these type of stabbing wounds on the street. But I think this was the first clamshell thoracotomy on the streets of Budapest.
That's a tough one. As I mean,
Yes.
I've ridden on the ambulances in Budapest, and they don't carry blood. They don't carry the Reboa, which
Yeah.
this might not have been appropriate because 3 to 4 centimeters a laceration. I mean, that's tough to suture. You can't use a Foley to plug the hole. I mean, TXA is only going to give what a 6% increase in coagulation option. And that's a really horrible situation, isn't it?
Yeah, unfortunately. So yes, you are right that the ambulance, they don't have those equipments you just mentioned, but the Hungarian helicopter emergency service, that's really well developed, and nowadays they have 2 packages of whole blood
Nice.
on the helicopters. Yeah, this kind of this stabbing happened during the night or late in the evening, so the helicopter was not operating. Yeah, but I think like for 2 years or 2.5 years, there is blood on the helicopters.
Nice. I'm really happy to hear that.
Yes.
We need to get that on the ambulances as well.
Yeah, I mean it's really expensive and it needs lots of logistics, but it's worth. So it truly saves lives given to the right patient.
So that's a horrible situation for any healthcare provider to be in, regardless of austere or in the streets of Budapest, where you have a few good hospitals close to hand. It's definitely a challenge.
Yeah. To sum up, I would suggest if you have a penetrating trauma, or if the injury is suggestive of penetrating trauma of the heart, and you are in the field in remote conditions, open the chest, because that's the only chance for your patient to survive.
Yeah, in the good hands of a good doc.
Have you Aebhric ever seen or done or?
Not on a human. I've done quite a few on live tissue, but I've never done been in an environment with a human.
Yeah, on the cardiac ICU, which is a cardiothoracic cardiosurgery ICU, sometimes it happens that the surgeon has to open the chest on the ICU in the bed, because there is a severe postoperative bleeding and there's no time to rush into the OR. In this situation, the surgeon opens the chest in 1 minute, but
Wow.
but he's a surgeon, and he opens chest every day, and also that chest it was just right closed after the operation, so it's the sternum goes really quickly, but otherwise in the field, even with some experience, I would say that it's at least 4 or 5 or a bit more minutes to get to the heart. Yeah, I'm really suggestive that if there's a penetrating trauma to the heart, as soon as possible, start and do it, because the patient has no other chance to survive.
Right. And now with ultrasound, we're very fastidious with doing a fast. By the time you do your fast exam and see blood in the pericardium, you're already 2 or 3 minutes behind.
No, I mean, open the chest if the patient is dead. So of course, if still alive and still has good hemodynamics or a bit hypotonic or whatever, so then you have time to decide. You can use your pocket ultrasound. Yeah, I mean, I've performed tons of ultrasounds, thousands of them, and so it's always very, very difficult in the field and in acute situations and in injuries, and the patient is in pain and moving a bit, and there's some blood in the thorax, there's some blood in the pericardium, or it's not really evident whether it's in the pericardium or it's just some lung tissue there. So it can be extremely tricky. If someone doesn't have a bit of experience in it, then I would not really recommend to make huge decisions based on a really quick ultrasound with a machine or with a probe, which doesn't give you the best image. Otherwise, if you have lots of experience and trust your ultrasound knowledge, then sure, if there's some pericardial collection, you can decide how to move next. But yeah, this suggestion to open the chest, sure, it's just in a CPR situation.
Yeah, and that's definitely a doctor level skill. As a critical care paramedic, I would be happy to assist, but that's not something I would do solo.
I would recommend to do it solo. I mean, if you are the head of your team and you were trained or just you've seen images, if you know in your mind what to do, then try to do it. If there's a penetrating cardiac trauma and the patient is dead.
Yeah, that's a hard decision, isn't it? It's 100% chance of death, or you can try a heroic measure of trying to sort this. But as you said, it comes to experience. And my live tissue models, I've done 30 or 40 of these teaching on porcine. Doesn't mean that I would be able to do this on a human by any means.
I think you would be able. And when there's a CPR situation, then you cannot cause more harm. I mean, anything is better than staying in that situation. So the patient can be alive with an open chest, but if it's a tamponade and nothing happens, then the patient will remain dead.
Yeah, and I think what you said with experience of having people be in the ICU and having this experience as a team and seeing this, it would definitely increase the chance of positive outcome on this.
Yeah, that's right.
Fair enough. So yeah, we talked about blunt, we talked about penetrating. Do you have any other thoughts on chest trauma?
Yeah, I think we've touched on the most important ones in details. I was also trying to give you guys some key points, how to recognize and how to manage. And just again, as a take-home message, I would say that trauma to the chest and to the heart is always critical condition. So you always need to be really, really proactive and do everything with your hands and with your devices to save a life.
Agreed. And get the experience to be able to be effective on this and spend some time in the ICU with cardiologists as yourself to have that hand knowledge as well as head knowledge.
Yeah.
Thank you, Dr. Gara, for your discussion on chest trauma, and we look forward to seeing you next month.
Thanks very much. It was great to discuss this topic with you today.
This has been a presentation from the College of Remote and Offshore Medicine Foundation. If you would like to earn CPD credit for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credits, free access to the virtual field guide, and discounts on our e-learning courses. You can join the team on the college website, which is Corum, Corom, corum.org.